Hello. Today we will be taking up another very important aspect of pediatrics, that is growth. As we have mentioned previously, growth and development are very characteristic changes in the pediatric age group. Today we will take up growth and we will talk about normal growth and how we assess growth. This is what we will focus on today. Now, what do we mean by growth? Definition wise, growth is a net increase of size or mass of tissue. But in a child, the growth does just not mean growing only in size. Like it's not like a balloon being inflated and inflated. It is increasing in size in a particular manner so that right from a fetus, the new conception gradually develops into an adult structure. Why is growth important? Growth is important because it is an indicator of the nutritional status, it is an indicator of well-being of the individual, it is an indicator of various diseases. Unless nutrition is proper, unless the child is getting proper care and is not sick, then only normal growth can happen. So we need to look into the growth of every single child. Before we take up growth, we need to focus a little bit on how changes happen. We all know that in the antenatal phase, we divide it into 3 stages. The undifferentiated ovum up to 14 days, the embryo from 14 days to 8 weeks, and then the developing fetus right from 8 weeks to birth. At birth starts the newborn period, which continues up to 28 days. Then from then to 1 year of age is infancy. After that comes the toddler age, that is 1 to 3 years. 3 to 6 years is preschool, 6 to 10 or 12 is the school-going age, followed by adolescence. Why are we talking about all these stages? Because at every stage, it's not just that the size of the individual has increased, but the proportions, the appearance, the growth of various parameters have also changed. What do I mean by all this? There are different dimensions of growth, not just size. So general growth, that is growth in size, is measured by weight and height. There is also growth of different systems, like the brain. The brain grows in size right from conception till adult age. Bones and muscles grow, lymphoid tissue grows, and sexual growth also occurs. And the rate of growth of all of these are not the same. They do not go at the same rate. Let us take a look at a chart which will explain. This is known as Kaman's curves. What we see here is the rate of growth is varying for different dimensions. The general growth is rapid in the first 2 or 3 years. Then there is a little bit of plateauing, only to increase again around the prepubertal age group and adolescence. On the other hand, growth of the brain occurs very rapidly in the early few years, and then there is a plateauing. So the major brain growth occurs during the first 4-5 years. Lymphoid growth, lymphoid tissue peaks around 8 to 10 years, whereas the sexual growth or the reproductive system is not growing much in the first few years of life, only to gain momentum during the adolescent period. So this variation gives rise to different structural presentation at different ages. That is why we needed, or we talk about those different stages. Okay, so at all these factors, all these changes happen because of various factors. So what are the common factors affecting growth? First of all, genetic. The genetic predisposition determines how a child is going to grow. So there is a familial trend, there is an ethnic trend behind which genetics plays a role. Also, there are certain genetic disorders leading to growth impairment. Next most important cause is the nutritional status. Nutrition directly affects growth. That is why to assess nutrition, we have to assess growth. Coming to the organic causes, endocrine factors affect growth. We know thyroid hormone, growth hormone, sex hormones, they all play their role more or less at different age groups. Illness, any sort of chronic illness may affect growth. And finally, the socioeconomic factors, starting from poverty to stress to nurturing care, they all have definite impact on growth of a child. Now, with this background of growth, then we know the importance of assessing growth. So how do we assess growth and what do we assess? Remember, for the general growth, we need to do some body measurements. So the child is growing in size. What can we measure? We can measure at one point. Right now, a child is brought to you and you will measure the various measurements like weight, height. We'll come to those later. Another aspect of growth measurement is the velocity study. That is, over time, how is the child growing? As we go on, we will discuss this in more details. So, coming to the different parameters, the most important parameter is weight. Regarding weight, we need to know what is normal in order to be able to assess whether growth is occurring properly, whether weight gain is proper or not. There are various formulae, but I will not go into that. The formulae are all present there in the textbooks. What I would rather try to give you is a quick impression about how this change of weight happens. So what is normal at birth? A normal birth weight is like 2.5 to 3 kg. Then a simple calculation is that the birth weight doubles at 5 months, becomes triple at 1 year and 4 times at 2 years. So a child born 3 kg will be 6 at 5 months, will be 9 kg at 1 year and 12 kg at 2 years. Then from in the second year, the weight gain is another 2 to 3 years, another 2 kg. 3 to 7 years, it continues at that rate of 2 kg per year. 7 to 10 years, it increases a little bit. That is the prepubertal spurt, where we generally get around 3 kg per year, followed by the pubertal growth spurt. During that puberty phase, weight gain may be like 6 to 8 kg over that period. Okay, now looking into the weight changes at birth. Body weight at birth does not begin to rise right from day one. We know that there is a little fall in birth weight, which is regained again by 10 days of age. And this fall in weight is because of the extra water content in the body of a newborn. From day 10 onwards, for the first 3 months, weight gain is 20 to 30 grams per day. That is why in the first few days in a newborn unit, we do a daily weight gain. We maintain a daily weight gain chart. So 20 to 30 grams per day amounts to 600 to 900 grams per month. After 3 months, this comes down to 400 grams per month. This is during the early neonatal period. Okay. So these are the different equipment used for taking weight. You can see the spring balance, the electronic balance, the beam balance. Various types are in vogue. Then we go on to measurement of height. Now we need to remember the few important points to remember here is height refers to the standing height. Now when do we take a standing height? Do we start taking a standing height the moment the child learns to stand? No. Up to 2 years, even if the child can stand, there's a little bit of stooping. So the height that we get is less than the actual height. So up to 2 years, we take the lying down length. After that, we will measure the height. And the instrument used is a stadiometer for the standing height and an infantometer for the lying down height. To take the height, maintaining a proper position of the child is very important, which will be demonstrated to you during your practical classes. Always remember that the child must stand straight with the heels touching the ground, the shoulder blades touching the wall, also the back, and the head should be straight. And how do we know that the head is straight? We look for the Frankfurt plane. The Frankfurt plane is a line drawn from the angle of the angle of the eyes to the tragus of the ear. And if this line is horizontal, the head is straight. Again, an idea about normal height or length. A baby at birth generally has a length of 50 centimeters. In the first year, it increases to 75 centimeters. So that is an increase of 25 centimeters. In the second year, there is an increase of 12 centimeters, coming to 87 at 2 years. Then the increase is 5 centimeters per year, roughly till 10 years of age, and 7 to 8 centimeters per year during the pubertal age. And one easy landmark to remember is that at 4 years, the expected height is 100 centimeters. So here we see a picture of an infantometer, and what is being done? The child is made to lie down, the head is held straight so that the highest point of the head touches the headboard, and then the knees must be straight and touch the ground level, and the feet should be at right angles so that the heel touches the baseboard. So these are a few points to be noted while using an infantometer. Okay, so height and weight taken at one point is what we have discussed. Beyond this, to really judge how a child is growing, we need to assess the growth velocity, that is the rate of growth over time. This will tell us whether the growth is faltering or not. Apart from height and weight, what other measurements do we take? We do the head circumference, we can do the chest circumference, and also the mid-arm circumference. These three are the most important. For the head circumference, what is the method? The tape we use, number one, should be non-expansile, not the one that changes size and expands on its own. So we prefer a fiberglass tape. And the points to be touched while taking a head circumference is the supraorbital ridge, the parietal prominence, and the occipital protuberance. Another point to remember is do not start measuring from the tip of the tape. We overlap. As you see in the picture, there is an overlap from this end and this end, and the measures are taken where they cross each other. See, if this is 5 and this is the point here is 45, then the measure will be 45 minus 5, that is 40. We do not take the measurement from one end. Okay. So why do we take the head circumference? Because the head size increases quite prominently in the first 2 years of life because of the quick brain growth, as we have seen earlier. So what is the expected head circumference? At birth, it is 35 centimeter. At 1 year, it increases to 47 centimeter, an increase of 12 centimeter. Remember, the length increased by 25 centimeter and head circumference is increased by 12 centimeter. But in the second year, this 12 comes down to 2. So from 47, it only goes to 49 centimeter. And at 12 years, over the next 10 years, only another 2 more centimeters are added. So it's a very quick increase in the first year, a little bit in the second year, and then very slow. Next we come to the chest circumference. Chest circumference is taken at the nipple level, midway between inspiration and expiration. What is the importance? The importance is because the head size is pretty actually the head size is increasing rapidly and the head is relatively large, we see that the chest circumference is less than the head circumference at birth and with a difference of around 3 centimeters. When do these two measures become equal? By 1 year of age. If by 1 year of age chest circumference is still less than the head circumference, that is an indication of malnutrition. Another possibility, of course, is huge hydrocephalus, but that is rare. Then we come to mid-arm circumference. When is it important? It is a very important marker of malnutrition. Less than 12.5 centimeter indicates moderate malnutrition. Less than 11.5 centimeter indicates severe malnutrition. Actually, severe acute malnutrition can be diagnosed with this one single parameter. But when is it useful? It is useful only between the age of 6 months to 60 months. And here you see a picture of the Shaki's tape, which is commonly used in the fields by the health workers. There's a color marking. The color marking of green, yellow and red will tell the health worker whether the child has moderate malnutrition or severe malnutrition. Okay. Finally, we come to the issue of body proportions. As we have mentioned earlier, it's not just the increase in size like blowing a balloon. Not only is the size increasing, but the body proportions are also changing as the child is growing up. What I mean is, if a 1-year-old child is somehow bloated and expanded to the height of, say, a 10-year-old, will this 1-year-old look like a 10-year-old boy? No. Similarly, if a 16-year-old boy is shrunken down to the size of a 1-year-old, will he look like a 1-year-old? No. That is because of the different body proportions. And as growth occurs, what happens? Growth generally occurs from above below, cephalocaudal, and from distal to proximal. So distal part of the limb grows first and the proximal part of the limb. First it's a linear growth and then the muscle path. And first it's the limb growth is followed by growth. Finally comes the shoulder and pelvic girdle growth. This is how the final shape of a adult person comes in from a baby shape. And what is very important here is the upper segment lower segment ratio. As we see in this picture, in the baby, if this is the midpoint, that is the umbilical, if we consider this as the upper segment and this is the lower segment, both are almost equal. Whereas in a 12-year-old child, the upper segment is definitely smaller than much less than the lower segment. So the ratio is changing. For a newborn, how do we measure? Okay, in an older child, upper segment versus lower segment, where do we do the measurement? The lower segment is measured from the symphysis pubis to the heel. And then from the length of the child or the height of the child, we subtract the lower segment value and we get the upper segment. So then we can take the ratio. Another measurement that is done is the arm span. The arm span, that is from, if we extend both the arms from the tip of the right hand to the tip of the left hand, this is the arm span, and that is compared to the length. So arm span versus length is another ratio that is taken. In an infant or in a very small infant, the measurement that we take is the crown rump measurement and the heel rump. How do we do the crown rump? Putting the child on the infantometer, we flex the thighs, and the measurement from the head to the rump, that is the buttock, is measured. This is the crown rump length, and subtracting that from the length of the child, we get the heel rump length. Okay. With this much about assessment, so we have some values, but how are values going to help us unless we know for whom this value is taken? So we have to match the value against something. And another thing is, as I said, it is the velocity, it is the growth that is happening over time that is very important, which we need to follow to understand whether the process of growth is progressing normally or not. So that is where comes in the importance of growth monitoring and following the assessment, following the figures that we have, putting them on a chart and following it up over time. This is what we call growth monitoring. So what we do here is regular assessment of growth at fixed intervals and following up the growth pattern as a vertical process. For this, what we need to do? We need to take certain measurements, most commonly the height and the weight. Now again, this height and weight is taken, it starts right from birth and it must be taken till 5 or 6 years of age. We can continue further, but it's very important during these first 5 years of age. Now, who does the growth monitoring? Every single child's growth needs to be monitored. So there should be a structure where every single child can be reached. For this, in our healthcare system, there are the Anganwadi workers, there are the ASHA workers and the ANMs who are doing it at the ground level, and doctors, particularly pediatricians. At every pediatric visit, we do a growth evaluation. Now, why? What is this growth evaluation going to tell us? It is going to tell us whether the child is growing normally, whether there is a sudden faltering, whether it may be an indicator of poor nutrition or some illness. It may be an indicator telling us that we need to intervene. And also, this monitoring will help us tell the parents that you need to improve on the nutrition, how you should take proper care of your child. For some parental awareness also, this monitoring is very important. Now, as I said, these are certain measurements that we are going to take. What are the common measurements? Height and weight. But only weight and height is not going to help. Suppose a mother comes in with a child and says, my child is not growing well. And you take the weight, you find that the child's weight is 12 kg. Is that enough? Enough information? No. We need to know the age of the child. If it's a 1-year-old child with 12 kg, it's overweight. 2-year-old, 12 kg, perfect. But a 6-year-old, 12 kg, the child is not growing properly. So the age, so there are two variables. Apart from the weight, we also need to know the age. Same for height. So what we look for is weight for age, height for age. Now suppose we do not know the age of a child. Can we do anything? Yes. For that we need some age independent criteria. The most common age independent criteria is weight for height. If I know the weight of a child and also the height of that child, what is the expected weight for a particular height? If that is not met, then the growth of the child maybe is faltering. So weight for height is important. Also mid-arm circumference. Mid-arm circumference is not dependent on age, provided I take it within 6 months to 6 years, the value is the same. Less than 11.5 indicates severe acute malnutrition. Another measurement is the BMI. So all of these criteria are taken into account when a chart is used, and what the weight that we take is plotted against either the age or the height, and that is followed up over time. This is how monitoring is done. So to sum up, for nutritional assessment, a child has been brought in, we want to find out whether the child has malnutrition. What will we do? We will do a weight for age, we will do a height for age, or weight for height, which is age independent. We can also do a BMI. In BMI, how is it calculated? Weight in kg divided by height in meter square. Also mid-arm circumference, chest circumference may be done. Another way of assessing nutrition is the skin fold thickness. The subcutaneous tissue is measured with a caliper. Finally, we will take up the issue of growth charts. Whatever value we have, unless it is plotted in a chart, it will not make sense. So let us look at the different charts that are used. There are certain international charts. Most commonly that we know of is the CDC chart, which was in vogue in various countries, including in India till a few years back. Then there's a WHO growth chart, which has been validated and constructed taking into account the values in different countries. We will not go into details. This is a chapter on its own. We'll talk about it later at some point. But remember, there are the WHO growth charts. And on top of it, right now we have some Indian charts, of which the IAP charts are also very useful. All these charts show the expected weight at different levels. And for this comparison's sake, two types of charts are in vogue. One is the percentile chart, the other is the Z-score chart. Before we look at these, let us go for a quick recap into understanding what we mean by percentile and Z-score. And to understand that, we need to do a recap on the normal curve. If you remember, if in a population we study the weight, say for a population of 2-year-old children, what is the weight that we get? We will get a range here. So this is the height of women. So we get a range of values, that is we're looking at weight of 2 kg children. The range may be from 5 kg to 15 kg. In this range, most of the children will have a central or the mean value, that is between 5 and 15, the mean is 10. We will find that the majority have a value near the central value. So that is the mean. Now that is how if this is the mean value, this is where the maximum concentration of people are. Then as the value for an individual, the further it goes from the central value, the less number of individuals will be having that particular value. So if we think about 5 kg, please ignore these numbers. This is a total. I'm just showing you the graph, the way it looks. If a child has a weight of 5 kg, that his value will be absolutely at the extreme end of this curve. So very few children will have a weight of 5 kg. But if it's 10, it's the mean, the majority will be having this. Now, how do we categorize this? Statistically, it is seen if we have a standard deviation, that is from the mean, if we take one standard deviation on both sides, say in our case, 10 being the mean, the standard deviation, if it is 2, then 10 minus 2 is 8 and 10 plus 2 is 12. So between 8 to 12 kg, this group of children will be falling and they will constitute 67% of the whole population. If we take two standard deviations, add one more standard deviation on both sides, so that makes it 6 to 14. 4 on both sides of 10. 6 to 14 would cover 95% of children. And 3 standard deviations will cover 99.5%. From this, we know now what we mean by centile. A child who has the mean value of 10 kg, 50% of children will have weight less than him because he's at the central point. If his weight is 5 kg, or rather if his weight is 5 kg, he will have 2% of the population having a weight less than him. So his centile is 2 centile, and this is 50th centile. More, if the child's weight is 14 kg, it will be the 95th centile because 95 children will be having a weight less than him. Only 5 will have more than him. So in this way, we can have centile charts. Another easy way of doing it is the Z-score. Z-score is actually equivalent to the standard deviation. There is a calculation, a more complicated one, will not go into that, but for easier explanation, Z-score 1 is equivalent to 1 standard deviation. So, from the mean, if a child has a weight within 1 standard deviation, his Z-score is within -1. If his value falls between 2 standard deviation, his z-score is between -1 and -2. So with this idea, we will look at the different charts. Okay, so this is the WHO growth chart. What do we see here? Here, this is showing the weight and this is showing the length. And the central line, this is a centile curve. The central line shows the weight for various ages starting from birth to 5 years. The weight, expected weight at the 50th centile. So this is the mean. Then for the different curves that are shown are according to the different centiles. So this is the 90th centile, this is the 95th centile, whereas this is the second centile. Okay, and now when we plot the weight of our patient, we will see on which line it is falling. Like this red line, this red point here, this child has a weight which at 3 years the weight was taken to be 6 kg, and this falls on which line? We will trace this line and find that this is the 25th centile. This is one way of doing it, and some of the other charts have z-scores, and the WHO growth chart presently goes by the z-score chart. These are the charts that are used in our health cards. These are easy for the health workers to follow. The green part is the normal part. This is the 50th centile, or the range from -2 to +2 z-score. And then is the yellow, which is -2 to -3, and red is less than -3. That is less than 3 standard deviations. Okay, I'll just show you one more example before we end. So this here, these two lines are showing the normal range of weight. That is between -2 to +2 standard deviation. Okay, here this, and we've been plotting, this is the growth monitoring, we've been plotting the weight of this child. It was going properly till 1 year, this is, and then at around 14 months there is a sudden decrease in the weight. The child has gone from within the normal range to subnormal, and this continues. Intervention is started, nutritional intervention is given, whereby the child again comes back to the normal. So this is where the growth monitoring is very useful in understanding when the weight is faltering and when to intervene, how to intervene, and also show that okay, with intervention it has worked and the child has come back. So with this, I will end today's session, where we have discussed about what we mean by growth, what are the parameters, what are the factors affecting growth, how we assess, how we plot, and what is growth monitoring. Thank you. With this, we end today's session. See you again for the next phase of growth management.